today's video is a hugely popular topic. It's been requested hundreds of times in the comment section all over my channel. We're going to be talking about diabetes drugs. Now, the way that I want you to conceptualize diabetes drugs is to basically break them down into type 1 diabetes drugs and type 2 diabetes drugs. And as I make this distinction on this flow chart that you're about to see, I'm taking a few liberties here because obviously there is some crossover depending on the severity of type 1 and the severity of type 2. But for the most part, you can separate these mentally into insulin being the treatment for type 1 diabetes and the oral agents or the oral anti-hyperglycemics being the treatment for type 2 diabetes. And just get comfortable with this distinction because this is really how it's going to appear on USMLE and on Comlex. Now, there are different types of insulins, and we'll talk about all of those first. And then we'll transition into the major topic of today's video, which are all the different oral anti-hyperglycemics. Just as an overview, we'll be talking about things like rapid-acting insulin, short-acting insulin, intermediate-acting insulin, and long-acting insulin. And then when we get into, again, the main portion of today's video, we'll be talking about all the oral agents, which include Metformin, sulfonylureas, Meglitonides, DPP4 inhibitors, GLp1 agonists, SGLT2 inhibitors, acarbose, thiazolidinediones, and amylin analogs. So, that's a mouthful. Don't get overwhelmed. I'm going to break all of this down, make it really palatable, make it super easy. I'll give you an awesome mnemonic to help you remember everything that you need to know, and you'll leave this video as a master of the pharmacology section as it pertains to diabetes drugs. So let's get started by talking about insulin. Now, basically, for the purposes of USMLE, Comlex, and even your in-class medical school exams, you're going to have to understand a couple things about insulin. The main part of that is going to be on a graph. You're going to have to know the peak time of the different insulins and how long the different insulins last. So while that's somewhat annoying, it's also nice to know that there's only 3 things you need to know about each insulin. You need to know the name of the insulin and what category it falls into. So, if, for example, a SPART is that rapid-acting, short-acting, intermediate, long, etc. You have to know its peak time and how long it lasts. And that's really it. So 3 facts about each insulin, not too much to memorize, arguably not as bad as learning an oral agent because there's no mechanism here. You just have to know, again, the name of the insulin, when it peaks, and how long it lasts. So let's go through these by category. So first we'll talk about the 3 rapid-acting insulins. And rapid-acting insulins will be depicted on this insulin level versus time graph as shown in red. So the rapid-acting insulins include Lispro, Aspart, and Glulisine. They have a peak time of somewhere around 1 to 1.5 hours. And these insulins last for 3 to 4 hours. Okay, so if you have a type 1 diabetic, these are usually the insulins that they're taking when they're eating a meal, or if their blood glucose is 200 and they need to correct that and lower it back down to physiologic range. This is the type of insulin that accomplishes that. It peaks at about 1 hour. It lasts for 3 to 4 hours, shown in my graph on red. The next group of insulins that we'll talk about are the short-acting insulins, which will be represented by blue. There's only one that you need to know, so this is pretty sweet for the purposes of memorization, and that's regular. So literally, they named an insulin regular. Not too hard to remember. Regular insulin, or short-acting insulins as a whole, have a peak of 2.5 hours and last for 4 to 6 hours. So these are longer lasting than the rapid-acting, hence the name short-acting. The next group is the intermediate acting, and the major player in the intermediate group, which is shown on my graph in purple, is NPH. NPH insulin has a peak of around 8 hours, and overall it lasts for 10 to 16 hours. Now please take this opportunity to notice that on the axis of my graph, the time in hours is not drawn to scale because I'm jumping from 8 to 16 to 24 just to illustrate different insulins. But intermediate acting insulin, specifically NPH, has a peak of 8 hours and lasts 10 to 16. The final category, shown in green, is the long-acting insulins, and there are 2 that you need to know, Glargine and Detamir. there's technically no peak time for the long-acting insulins, and these last for 24 hours. So these are the insulins that your type 1 diabetics are going to take once a day, and this replaces the basal functioning of their pancreas. So normally, all humans that don't have type 1 diabetes, your pancreas is, outputting a teeny bit of insulin throughout the day just to keep you in that normal physiologic blood glucose range. But type 1 diabetics, of course, don't have that ability because their pancreas has destroyed its own beta cells, and therefore there's no insulin production whatsoever. So to replace that basal functioning that our pancreases all usually have, there's going to be long-acting insulin taken once a day, and because it's not peaking and it's just giving you some baseline coverage throughout the day, it's acting as the basal rate. So the long-acting insulins are really nice in that they don't peak. They last for 24 hours. They're taken once a day. Now, I know what you're thinking here. You're going, okay, that's not too much information, but how am I going to remember which insulin belongs to each category? And I've got some pretty sweet mnemonics for you. So the first one is that rapid insulins do not lag. LAG, lag, for Lispro, Aspart, and Glulisine. Rapid-acting insulins do not lag. The second mnemonic is regular and short. So to remember that regular insulin is in the category of short-acting insulin, just remember the mnemonic regular and short. The third one is that intermediate insulins are not particularly hasty. NPH, not particularly hasty. The insulin's name is literally NPH. So just remember that intermediate is not particularly hasty, which of course means that it's not too fast acting. And then our final mnemonic is, goddamn, 24 hours is a long time. GD for glargine and detamere. So these are 4 mnemonics, literally one short sentence or one short phrase for each of our 4 categories that will help you remember which insulins belong to which class. Again, before I transition to the type 2 oral agents, just remember, you only need to know the name of the insulin and which category it belongs to, the peak time, and the total duration time. So when does it peak, how long does it last, and which of these 4 categories does it belong to? Come back to this slide if you want to review the mnemonics, but if you just memorize these short phrases, you should be good for all of the insulin category. So let's just do a check-in. We've so far covered all of the type 1 diabetes medications, namely the different types of insulins. Now we're going to transition into what will be the bulk of today's video. It'll take up most of today's video. It'll be the scariest thing for your eyes to look at on the slide, but at the end of the day, you're going to know all of these oral agents just fine. So let's begin our conversation about the type 2 diabetes medications, and these are all of the different oral anti-hyperglycemics. So we'll start this conversation by talking about the prototypical type 2 diabetes oral agent, and that's metformin. You might see this written as the biguanide because that's the category of medication, but because metformin is really the only biguanide that you need to be familiar with for USMLE, Comlex, and medical school, we just say metformin. We don't say biguanides. The mechanism of metformin is that metformin inhibits, well, it really does a few things. It inhibits hepatic gluconeogenesis. It increases glycolysis. It increases peripheral glucose uptake. And the net effect of all 3 of those actions is that it's decreasing glucose. And that is the mechanism by which it treats type 2 diabetes. The adverse effects of metformin, and the one that you really need to remember if you take anything from this slide, is that metformin causes lactic acidosis in renal insufficiency. And we'll talk more about that in just a moment. The other 2 adverse effects to know is that metformin can cause a B12 deficiency, and it also tends to cause a little bit of GI upset. Now let's talk briefly about this lactic acidosis, which is especially common in renal insufficiency. Lactic acidosis can be fatal, so that's why this adverse effect needs to be talked about. So you've got your kidneys here, and normally metformin is excreted by the kidneys. So somebody takes metformin, it goes through the system, enters the kidneys, gets filtered out, and is excreted through the kidneys. Now, there's a certain situation that you'll encounter a lot once you reach your clinical years of medical school, which for most people is still the 3rd year of medical school. And that's somebody's, on the internal medicine service, admitted to the hospital, and they need to get a CT scan. usually, not always, but a lot of the time in different imaging modalities, people are going to be given contrast. Contrast enhances the image. I'm not going to get into radiology right now, but it enhances the image and provides more clarity for the physician to look at when the image is done. And what happens when you give somebody contrast is that contrast actually can cause what's called a contrast-induced nephropathy. So it basically temporarily damages and inhibits the kidney's normal function. And what happens in the case of a patient who's taking metformin is that because the kidney is usually excreting metformin, if you have a contrast nephropathy and temporarily contrast reduces somebody's renal function, then the kidneys cannot excrete metformin, and therefore metformin builds up. And when metformin builds up, because it has a propensity to cause lactic acidosis, this can actually cause a fatal, toxic lactic acidosis. And people die from this, so it's very serious. This is why when you get into the hospital in your third year of medical school, or whenever you're going to be starting up on the floors, you'll notice that for a lot of patients that get admitted to the hospital, their metformin will be held. Meaning when they're admitted, the resident or the attending that's admitting them to the service is not going to continue their metformin. And the reason that that's happening is not necessarily because metformin is super toxic. It's actually quite safe of a medication. It's because the person who's admitting them to the hospital isn't sure if they're going to need contrast. And therefore, if there would come a time in the next day or two where the patient will need contrast as part of their imaging, it's just easier if the metformin is already out of their system. So metformin usually gets held when somebody gets admitted to a hospital. Now, how do you remember this? This is the biggest point, the most high yield thing to know about metformin. Well, metformin starts with MET, and of course, lactic acidosis is a type of metabolic acidosis. So you can remember this major adverse reaction in metformin by remembering MET, because again, lactic acidosis is a type of metabolic acidosis, and metformin can cause it. So that's metformin. Again, know the mechanism, but please know this adverse effect of lactic acidosis, especially in the setting of renal insufficiency. It's very, very important. And clinically, once you start practicing, you're going to need to remember this. Let's talk about our next category of medication. So we will transition to the sulfonylureas. The sulfonylureas have a mechanism, and what they do is they increase the release of insulin. The adverse effects of sulfonylureas are hypoglycemia and actually a disulfiram-like reaction. The mechanism of sulfonylureas is that it's increasing the release of insulin by depolarizing the potassium channel. So I've put a little schematic on the slide so you can see what that looks like. But basically, the sulfonylurea drug blocks this channel, depolarizes the cell, calcium channels are opened, and you get the release of insulin. That's how sulfonylureas work. The sulfonylureas are the drugs that end in IDE, I-D-E, glimepiride, glipizide, and gliburide. And the way that I remembered this back in the day was my mnemonic is thinking about talking to somebody who has type 2 diabetes. And what better example than Wilford Brimley? I don't know if you remember the Wilford Brimley commercials, but they always started off with him sitting on a nice couch in a beautiful living room, and he, in his little southern accent, said, "I'm Wilford Brimley, and I have diabetes." And then he would talk, he'd pitch some diabetes-related drug or device. So what you want to do in this mnemonic is you think about talking to a type 2 diabetic, and you tell them, "I'd take your sulfonylurea. If I were you, I'd take your sulfonylurea." And that reminds me that all of the sulfonylureas have IDE, I-D-E. They end with IDE. You tell them, "I'd take your sulfonylurea." So that's it for sulfonylureas. Again, usually the biggest challenge for medical students and other graduate health professionals is grouping the drug into the right category. So like if you get a practice question and it says, which of the following drugs has the mechanism of blah, 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 and one of the answer choices is gliburide, if you don't know that gliburide is a sulfonylurea, even if you know the mechanism of the sulfonylureas, you just won't get the question right. So these mnemonics are to help you remember what category these drugs belong to. So let's do a brief check-in now. We've talked about metformin. We've talked about sulfonylureas. We are making progress as we move through the oral anti-hyperglycemics. Let's keep it rolling by talking about the next category, the meglitonides. Now, the meglitonides are almost identical to sulfonylureas. They end in "ide," as you see on the slide, and their mechanism is basically the same exact thing, but the only caveat that I want to throw in here is that they do it by a different binding site. So the sulfonylureas blocked and depolarized a binding site on the potassium channel. Although the meglitonides have the same cascade of events, they bind to a certain area, they cause depolarization, calcium channels are opened, and insulin is released. They do it at a different binding site than the sulfonylureas, but everything else about these drugs is nearly identical. So for the purposes, again, of USMLE and COMLEX, I want you to think of meglitonides and sulfonylureas of doing the same exact thing, having both of them end with "ide," IDE, and both of them can cause hypoglycemia. So like the sulfonylureas, my mnemonic for meglitonides is the same thing. "I'd take your meglitonides." So you need to remember "I'd take your sulfonylureas" and "I'd take your meglitonides," because these drugs also end in "ide," as you see at the top of this slide, nataglinide and repaglinide. I'm butchering the names, I'm sorry. But the big point, again, they end in "ide." "I'd take your meglitide." Let's talk about the next category of medications. These are the DPP4 inhibitors. These are drugs that end in gliptin, linagliptin, saxagliptin, sitagliptin. They all end in liptin or gliptin. The mechanism of DPP4 inhibitors is obviously, as the name implies, they inhibit DPP4, which in turn potentiates GLP1. And don't get overwhelmed by these acronyms. I'll talk about what this looks like in just a moment. The adverse effects of DPP4 inhibitors are somewhat unique, so you definitely need to know them. They are urinary infections and respiratory infections. The biggest thing is to understand what this mechanism is and how it works. So let's take a moment to dive deeper into this. So imagine that you eat a juicy hamburger. People who aren't in the United States are like, "God, you Americans and your filthy diet." But let's just imagine that you eat a hamburger. What normally happens is when you eat something, the body releases glucagon-like peptide 1, or GLP1 for short. And what glucagon-like peptide 1 leads to is it promotes insulin release and inhibits glucagon release. Okay, so that's the normal functioning of GLP1. But there is an enzyme in the body known as dipeptidyl peptidase 4, or DPP4 for short. And what DPP4 does is it inhibits glucagon-like peptide, basically knocks it out. So if you have this enzyme that's normally present in the body, which normally destroys or inhibits GLP1, you do not get insulin release. You do not get the promotion of insulin release. You do not get the inhibition of glucagon release. And therefore, you can your blood glucose can be higher than it otherwise would be, because you're not getting the release of insulin and you're not getting the inhibition of glucagon. So what a DPP4 inhibitor does, perhaps obviously if you look at the name, is it inhibits that enzyme. So it inhibits DPP4, which means DPP4 is not available to inhibit GLP1, which means that there's disinhibition of GLP1, which means there's more promotion of insulin release, shown in green, and more inhibition of glucagon release, shown in red. And the net effect of that is to lower glucose levels, which is how it treats type 2 diabetes. So that's how a DPP4 inhibitor works. These are the drugs that end in liptin, linagliptin, saxagliptin, sitagliptin. Now, while we're talking about this mechanism, let's look at the GLP1 agonists, since the mechanisms are so closely intertwined. So the GLP1 agonists are exenatide and liraglutide. So these end in tide, T-I-D-E. The mechanism of the GLP1 agonists, as the name suggests, and as you just saw on the previous slide, is that these potentiate GLP1, or glucagon-like peptide 1. The adverse effects of the GLP1 agonists, also a little bit unique, so know it. It's pancreatitis. Now let's go back to our slide that we just talked about. When we looked at the DPP4 inhibitors, what you can see is that another way to stimulate insulin release and another way to promote the inhibition of glucagon release is to use a GLP1 agonist. A GLP1 agonist just potentiates this process and makes it happen faster. So the big takeaway from this slide is that DPP4 inhibitors and GLP1 agonists, They both work in a similar fashion in the sense that they're both promoting the same process. They just do that differently. So how are you going to remember this? And more importantly, how are you going to remember the different drugs and that they belong to these two individual classes? So let's look at GLP-1 agonists first. You'll notice that they both end in tide. And when I think about GLP-1, I think about gulp, GLP, gulp, like the sound that somebody makes when they're swallowing, gulp. And I don't know if you guys remember, but a few years ago, there was this really stupid thing called the Tide Pod Challenge. And there were these idiot teenagers swallowing Tide Pods. Tide, for anybody that doesn't know, Tide Pods are like laundry detergent pods that we put in our washing machines here in the US, and it cleans our clothes. So the way that I remember this is I think about somebody gulping down Tide Pods. These idiots thought this was a good idea, and it really wasn't. But it went viral on social media. So gulping down Tide Pods is how I remember that the drugs that end in Tide belong to the gulp or GLP-1 category. And here's a clipping from New York Times that talked about this when it happened. Yes, people are really eating Tide Pods. It was insane. But that's America for you guys. Now let's talk about DPP4 inhibitors. You'll notice that all of these drugs end in leptin. And that reminded me of a famous brand of iced tea called Lipton iced tea. And as anybody knows, iced tea and tea are diuretics. So the way that I remember this is that Lipton makes you pee 4 more times. And this is awesome because it's Lipton tea makes you pee 4 more times, or PP4 for DPP4 inhibitors. So you've got all these drugs ending in Lipton. Those are your DPP4 inhibitors, and you memorize that with my stupid mnemonic that Lipton makes you pee 4 more times. You'll never forget this if you write this down and can remember Lipton tea or Lipton iced tea. Let's do a little check-in and see where we are. At this point, as far as the type 2 diabetes drugs, as far as the oral anti-hyperglycemics, we've now thus far talked about metformin, sulfonylureas, Meglitonides, and then we just previously on the past few slides grouped in the DPP4 inhibitors and the GLP-1 agonists because they worked it through similar mechanisms. Let's talk about the SGLT2 inhibitors. And these are the drugs that end in flozin. So canagliflozin, dapagliflozin, and empagliflozin. The mechanism of the SGLT2 inhibitors, as the name suggests, is that it inhibits a cotransporter called the sodium glucose cotransporter 2, and that's what SGLT2 stands for. And what happens is when you inhibit that cotransporter, you're decreasing the reabsorption of glucose in the proximal convoluted tubule of the kidney, and we'll talk about that mechanism more in depth in just a moment. The adverse effects of SGLT2 inhibitors are very unique, and they'll make a lot more sense after we talk about the mechanism, but they include glucosuria, urinary tract infection, and vaginal yeast infections. They also can include hyperkalemia and dehydration. These adverse drug effects, especially the 3 on the first line there, glucosuria, UTI, and vaginal yeast infection, these will make a lot more sense if we dive into the mechanism. So let's do that now. So I want you to imagine that we're in the nephron. We are in the proximal convoluted tubule, and glucose is flowing through. So you drank some orange juice, the glucose in your body has been increased, and now it's flowing through the nephron. Normally, for glucose to be reabsorbed into the system, which in effect makes glucose higher in the body, glucose is reabsorbed through a cotransporter, and that cotransporter is the sodium glucose cotransporter 2. It's shown here in light blue. And as the name suggests, it's a cotransporter that operates with both glucose and sodium. Now, normally, as I said, under normal physiologic conditions, the body is detecting glucose flowing through the proximal convoluted tubule. It knows exactly how much glucose to reabsorb, and it does that to maintain glucose balance. But in a type 2 diabetic, obviously their blood glucose tends to run a bit high, and the goal is to decrease glucose in the body. And one of the ways that we do that is by giving somebody this SGLT2 inhibitor. And by inhibiting the reuptake of glucose through these cotransporters, we're effectively blocking glucose from being reabsorbed, and instead the glucose will flow through and get urinated out. Now, if you think about that, The mechanism makes sense about how you decrease glucose, but the adverse effect makes even more sense. So recall that the adverse effect was glucosuria, so more glucose in your urine, which causes both urinary tract infections and vaginal yeast infections. And that should make perfect sense to you guys. If there's more glucose in the urine, it's more of a nidus for some type of pathogen to utilize that glucose as fuel to infect the urine and for yeast to grow on the vagina or in the vagina. So again, the adverse effects, glucosuria, UTI, and vaginal yeast infection should make perfect sense considering the mechanism basically leads to more glucose in the urine. Now, how do you remember that the Flozin drugs are the SGLT2 inhibitors? Well, this is really easy. Just remember Flozin through the urine or Floin through the urine. And that will remind you that the drugs that end in Flozin or Floin all go through the urine and are SGLT2 inhibitors. Now let's talk about alpha glucosidase inhibitors. And the major drug here that you need to know is acarbose, but the secondary one that sometimes shows up is also Meglitol. The mechanism of the alpha glucosidase inhibitors is that these inhibit intestinal brush border alpha glucosidases. And you might remember that the alpha glucosidase enzyme is present in the intestinal brush border back from the GI section. The adverse effect here, again, this will make more sense after we dive into the mechanism, but it's GI upset, gas, and bloating. So let's just take a visit to the intestine. You've got these oligosaccharides, which are basically the precursor components of glucose that have not yet been broken down into their monosaccharide derivatives. Basically, glucose is a monosaccharide and it comes from oligosaccharides. So as these oligosaccharides flow through the intestine, they pass the brush border, which has this enzyme, alpha glucosidase, just chilling on the side. And that alpha glucosidase catalyzes the conversion of the oligosaccharide to its monosaccharide glucose derivative. And then once that monosaccharide glucose derivative has been made, which again, that whole conversion is done by alpha glucosidase, that glucose can be absorbed through the intestinal wall and lead to higher glucose levels in the body. Now, normally, as I said, with other drugs as examples, the body knows exactly how much glucose it needs to absorb to keep a perfect balance. But in type 2 diabetes, that balance is just not working. And one of the ways to decrease glucose is to prevent this absorption of glucose through the intestinal wall. And one of the ways we do that is by giving alpha glucosidase inhibitors. So if you inhibit the enzyme that converts the oligosaccharide into its monosaccharide glucose derivative, you never have the availability of the monosaccharide glucose to be reabsorbed. So you basically knock out this process. You've got oligosaccharides just sitting in the intestines, and they'll proceed through the intestines and get excreted in the feces. And if you think about this, the adverse effects should make perfect sense, because if you have more oligosaccharide in the intestine, it's going to cause a little bit of GI upset. It's going to cause a little bit of gas, a little bit of bloating. Now, I know what you're thinking. How do I remember that acarbose is an alpha glucosidase inhibitor? And that's pretty easy, because acarb literally means without carbs. So you're never getting the glucose because you're never converting it, and therefore the intestine is without carbs. So that's how I remember alpha glucosidase inhibitors. Again, the big one is acarbose. So here is where we are so far. You guys are making awesome progress. If you're following me, we've talked about metformin. We've talked about sulfonylureas. We've talked about meglitonides. We've talked about both the DPP4 inhibitors and the GLp1 agonists. We've talked about SGLT2 inhibitors and how they're very unique in the kidney. And now we've talked about acarbose and how it's very unique in the intestine. Let's wrap up by talking about the final two categories of the type 2 diabetes drugs. The next one is the thiazolidinediones, and that's the hardest one to say by far. These are your drugs that end in glitazone, so pioglitazone and rosiglitazone. The mechanism of the TZDs, as I will call them because I do not want to pronounce that drug name again, is that these bind to the peroxisome proliferator activated receptor gamma, or PPAR gamma, binding site, which is just a nuclear factor. And the net effect of that nuclear factor is to increase insulin sensitivity. The adverse effects of the TZDs are somewhat unique: heart failure and increased risk of fracture. So definitely know the adverse effects of all these drugs because they're all pretty unique. How do you remember this? This is a tough one because the name is so weird. But if you look at the drugs, you'll notice that they all have glita or glitter if you like to party in the name. And that reminds me of glitter, like throwing glitter up in the air, or confetti, some type of party material. And my mnemonic here is that you want to bring glitter to the party. Glitter for glitazone and party for PPAR helps me memorize the